Thank you, Ashwin, and thank you, Coach Up. So let's see. Get to here. There we go. Can everybody see my screen?
Full screen, yes.
Yes, Kevin.
All right. Yeah, so we have the problem often nowadays with premium IOLs. We have premium expectations and sometimes sub-premium results. So I'm going to present such a case that came to me just actually 4 weeks ago. So she was a 68-year-old woman. She had left eye cataract surgery with another ophthalmologist. And at that time, a PanOptix lens, 24 diopter natural PanOptix lens was implanted. And then following surgery, she looked like the picture on the right. She had a 6 mm dilated pupil. You can see the opacified anterior capsule, the capsule rectus is a little bit small, a little bit displaced. And she had trials of bromonidine and pilocarpine that didn't help reduce the size of her pupil at all. And we don't really know why her pupil is blown. You know, I suspect she had a post-op pressure spike, but she didn't have any of the symptoms of that. And the records from the other doctor didn't indicate any high pressure. So we just don't know. But she did complain of poor vision, photophobia, glare sensitivity, and she also had a negative dysphotopsia on top of all of it. And because of the lack of any history of high pressure, she actually went through a neurological evaluation, even had an MRI scan by an outside neurologist. That all of that was negative. Her uncorrected distance field acuity was 20/40, as you see with that picture. Her corrected vision was 20/30 +3 with a small refractive error. Posterior segment examination was unremarkable. So she had essentially two problems, and they're shown here in the same picture. One, she has a quite enlarged pupil, and secondly, she has a small capsular rectus that's associated with an opacified peripheral anterior capsule. So how would you attack these problems? Because they're both contributing to her overall poor quality vision. So clearly she needs additional surgery. We did a look at her endothelium, and there was 1,302 cells on the back of her left cornea, thought sufficient to go back inside her eye. And so we did it. This is what she looked like on the operating table under the operating microscope. And you can imagine if that was you, the type of glare sensitivity and just visual disturbance that you would experience. So we decided to tackle both of the problems, do a capsulotomy enlargement first, and then go and do a pupilloplasty secondarily. So I'm going to show you the entire video sped up to 8 times so you can see all the little mistakes I make along the way. Get the little button to clear. There we go. So this is what we do, a paracentesis, viscoelastic injection. You need to get viscoelastic under the capsule. So I do that by using a 30 gauge needle. So that lifts the capsule. Now once I have space, then I can take my cannula under there and visco dissect the capsule off. So you need scissors, you need a combination of scissors.
That now, the other one, not this one. You know.
Scissors and capsule rectus forceps. You can only tear so far, and then you hit a wall, and then you do a little more scissor work, and you try to tear. Oftentimes this is what happens. It's very resistant to tear. Sometimes you get little stretches where you can tear it, like I think I'm going to here's a stretch where I can actually tear the thing. Oftentimes you're peeling out subcapsular fibrosis at the same time. That's what I'm doing here. The obligatory air injection. And then I couldn't finish it by tearing it, so I ended up just basically finishing off the thing by cutting it. So again, we're using micro scissors, micro capsule rectus forceps, but in the end, I was able to get a capsulotomy open that was about 5 millimeters in diameter. So part 1 done, and then we'll just clear out the viscoelastic here. So that's not sufficient though. She still has a very enlarged pupil. So on to part 2. So here's I'm going to show you just a standard suture pupilloplasty. Amar has become the world's expert on this whole process. I made 2 mistakes here, and I'm going to show you my mistakes. If I can get the little video thing to show up. Oh, here we go. There we go. So another paracentesis. So I'm sitting superiorly here. I'm going to pass my first needle in inferonasally, and then we just kind of loop it around the pupil using the micro graspers to feed the iris over this CIF4 needle. This is a 10-0 proline. We'll dock it to a cannula and then come out. You need to dock to a cannula so you don't end up spearing the cornea and grabbing corneal fibers on the way out. So then we go back in the same spot and loop around again and again and again, cannula in and then come out. And then I need to turn my microscope, so I'm sitting temporally, so I'm doing right now, I'm reorienting the microscope, and then I'll continue going around clockwise. Now I'm going from superotemporal to inferotemporal. Now, I made the mistake of cutting off the other needle. I should have left this double arm. You're going to see why in just a minute. I was just going to finish it off, just going in the direction that I'm going, but I am so clumsy with my left hand. Hear me, I am needle in my left hand, and I can't do this for the world. It's just so awkward. Problem is I already cut off the other needle. So what to do here? I'm fumbling. Screw it, I can't do it. So finally, I tied another needle on to the cut end, and then I went back to sitting superiorly, and then I made my second mistake. And you're going to see it here. When I went in to the inferonasal incision, I snagged some corneal fibers right there. Didn't know it until after the needle was already in the eye, and I looped the pupil margin. Now, fortunately, I didn't snag a lot of corneal fibers, and you'll see I can get out of this one. So we're going to finish up by coming out the same paracentesis that we started in. And then I'm going to pull on the proline suture, and watch the iris goes right up to the incision. So fortunately, it wasn't a lot. I grabbed it and yanked it with both sides, and I was able to get it to uncatch. And then the next challenge is sizing the pupil. Now we're going to tie this kind of like a mechanical suture technique. So you end up kind of pulling the iris up to the incision, and you hope when you tie the knot, you tie it at the right size, but you're not tying it centrally, you're tying it kind of eccentrically. So it's just kind of a lot of guesswork. And of course, the pupil never looks perfectly round. It looks scalloped whenever you suture like this. So you have to promise these patients you're not going to have a round pupil at the end. Hopefully it'll be better than what you started off with. And then the last thing you don't want to do is you don't want to cut the knot here. So you have to be really careful to cut the suture ends and not the knot, because then you start all over, which I didn't do that. You can see the iris atrophy. I'm pretty sure she had a pressure spike. So we're going to take out the viscoelastic now. Again, you've seen the entire operation because I've done the whole operation in front of you just at 8 times normal speed. Hydrate the incisions, pressurize the eye. And at the very end, you'll see me right here, I inject some moxifloxacin, and that's the case. There's the moxifloxacin. So what did she look like afterwards? Well, here she is. Left is pre-op and then right is post-op. This is 2 weeks post-op. And in retroillumination, here she is before on the left and after on the right. You can see the multifocal IOL is nicely centered, and we don't have any edge showing. So post-operatively, her glare symptoms were much improved. Her uncorrected distance visual acuity was still 20/40, which is what it had been pre-operatively. Her CDVA, her corrected distance visual acuity, was 20/25 now, with a relatively small manifest refraction. But it's not over for her yet. The next step in her care process will be a posterior capsulotomy with the laser. And if she's chasing the dream of perfection and wants to be 20/20 uncorrected, we may even do a little touch-up post-op PRK with her at some point down the road. But that's where she is right now. So thank you for letting me present, Ashwin.
Thank you, Kevin. That was simply wonderful. And the kind of expertise that you have, I didn't think that was possible for me to do that purse string suture. That was really, really neatly done. Even though you said there were a lot of snags, I didn't see those snags. I only watched the end of the case. It looks beautiful. Thank you so much.